Hello to all. I am Vishnu. So today is the last part of RNTCP guidelines for tuberculosis. It actually doesn't mean that I am ending the tuberculosis series. I'll come back with pathophysiology, how it happens, and what are the symptoms, and what are the interesting features about individual drugs that are used in tuberculosis. I'll come to that later. This series was actually about RNTCP guidelines. So I have made it in that way. So this is going to be the last part. Here we are going to talk about two individual things. First is if a patient is having ADR towards first line anti-tubercular agents, what can we do? And the second thing is about DELAMANID, which is a newer molecule. Actually, it's not new. It's around 3 years old or 3.5 years old now. So we'll talk about that as well. So first we go into treatment of patients with ADRs to anti-tubercular drugs. Even though first-line anti-tubercular drugs are well tolerated, minor ADRs may occur. Actually, it is not minor. If you look at some of the ADRs that happen due to first-line anti-tubercular agents, they are actually notorious for some population and some risk factor agents. So, but even then, we can say generally that some ADRs may occur. They are usually resolved by symptomatic management without necessitating drug discontinuation. So if minor ADRs are occurring due to first-line anti-tubercular drugs, we usually look at the risk versus benefit ratio and we do the treatment accordingly. So for example, if nausea or anorexia is happening due to first-line anti-tubercular agents, we can administer the medication with small meals. If drowsiness is happening due to first-line anti-tubercular agents, we can give those before bedtime, so that even if drowsiness happens, the person can sleep. And anyways, you can derive a practical knowledge from this, that if a patient is already suffering from insomnia, and if any of the first-line anti-tubercular agents are causing drowsiness as a side effect, that may be beneficial to be given at bedtime. So it can be a blessing in disguise, although it is a side effect. If pyrazinamide causes arthralgia, actually we'll talk about all these things in later sections when I talk about interesting factors about anti-tubercular drugs in future videos. So pyrazinamide causes arthralgia. Arthra means bone, algia means pain. Arthralgia means bone pain. So we may give analgesic NSAIDs. And if isoniazid-induced peripheral neuritis occurs, usually peripheral neuropathy and all, then pyridoxine can be used. But usually we do not wait for peripheral neuropathy to happen. Usually when isoniazid is given, pyridoxine should be given to such population, whether it is a pediatric, whether it is an adult, whether it is a geriatric, or whether it is a pregnant population. Pyridoxine should be given. If severe reactions occur due to first-line anti-tubercular agents, you should first stop all the drugs completely. So this is actually, I'm going to talk about de-challenge and re-challenge concept. So de-challenge concept means if, for example, 4 drugs are used in a patient and the patient developed hepatotoxicity. Now you are not sure as to which drug caused hepatotoxicity. So what you will do is you will stop all the 4 medications and wait for the hepatotoxicity to resolve on its own. Once the hepatotoxicity resolves, we will start one by one drug, one at a time. Anyways, whenever we start one drug at a time, if the patient's hepatotoxicity comes back, we will easily be able to understand which medicine was responsible for this condition. So that is called de-challenge and re-challenge. De-challenge means we are stopping all the medicines because we doubt that any of this may be the reason for the ADR. And re-challenge means we will start all these medicines one by one. Again, I'm saying one by one, not together. Because again, if you are starting all the medicines together, and if again the same ADR happens, we'll never be able to understand which is the culprit molecule. So if severe reactions occur due to first-line anti-tubercular agents, we will stop all the drugs promptly. Once the severe side effect is resolved, we will introduce those drugs one at a time. So that is called re-challenge. Challenge with small doses and increase the dose every 3 days. Again, I'm saying we will introduce the drugs one at a time. We are not going to introduce all the drugs together. We will introduce the drugs one at a time. First, we will start with small dose and then we will increase the dose every 3 days. So anyways, if any of this medicine is the culprit behind the severe reaction, we will come to know very soon. So if the offending drug is identified, we will stop that drug and we will reconstitute the treatment regimen. That means we will stop that medicine and we will think of any other medicine that can be used as a substitute to it. Or we can even think that if that medicine is not there, can we carry on the therapy with the remaining agents? So this is called de-challenge and re-challenge concept. Never reintroduce rifampin in cases of hemolysis, thrombocytopenia, and renal failure. Always remember. If rifampin-induced hemolysis is seen or hemolytic anemia is seen, please don't reintroduce it. It can be life-threatening. If rifampin causes thrombocytopenia, never reintroduce it. It can be life-threatening. If rifampin causes renal failure, never reintroduce it. It can be problematic. So here you have seen that never reintroduce rifampin in cases of hemolysis, thrombocytopenia, and renal failure. So you can derive a practical knowledge from it. If rifampin causes hemolysis, that means rifampin should not be used or should be very carefully used in a patient who is already suffering from hemolytic anemia. If rifampin causes hemolysis, it should be very carefully used in a patient who is suffering from hyperbilirubinemia. Why hyperbilirubinemia? Because when hemolysis happens, what is hemolysis? It is the spontaneous destruction of RBC. When there is spontaneous destruction of RBC, large amount of bilirubin is released. So that causes hyperbilirubinemia. So for example, rifampin is used in a tuberculosis patient who is already suffering from jaundice or severe hemolysis, then it may increase the bilirubin levels. If rifampin causes thrombocytopenia, you should be very careful when you are using rifampin with antiplatelet agents. Although rifampin is a very powerful enzyme inducer, so naturally it will reduce the plasma drug concentration of other molecules unless and until they are not prodrugs. But still we have to be very careful. So rifampin in thrombocytopenia is not a very good indication or not a very good sign. And definitely in renal failure. So for example, already the patient is suffering from CKD. And there if we are using rifampin, then it may exacerbate the situation. Discontinue ethambutol at first sign of optic neuritis. I personally tell people that if it is a pediatric below the age of 5 and if it is an unconscious patient, no matter what happens, don't think about ethambutol. And if it is a normal conscious patient who can speak, please advise the patient to report sign of blurred vision, even if it is at the minute level, because this may be the symptom of optic neuritis. Now we can derive another practical knowledge from this. If ethambutol is used in a diabetic retinopathy patient, for example, there is a patient who is suffering from diabetic retinopathy. So definitely they are having cataract or glaucoma, something related to that because of diabetic retinopathy. And if that patient is suffering from tuberculosis and we are using ethambutol, it can be problematic because ethambutol anyways will cause blindness due to optic neuritis. So already in glaucoma or cataract, you know what happens. So there can be a connecting link. So this is how actually we should study. PharmD, or it's not just about PharmD. Whether you are studying anything related to medicine, it is not about simply studying a particular point. Pharmacy practice is not about looking at the sky and counting the stars. Pharmacy practice is about connecting those stars and creating a constellation. Because if you keep on counting how many stars are there in the sky, you will never reach anywhere because there are billions of stars. But if you create a constellation looks beautiful. So whenever you study the side effect of a particular medicine, always remember that you try to think where else we can connect this. Like for example, I was saying another day to a person that linezolid, which is an antibiotic, it causes lactic acidosis. Now you may think, which are the other? Now you should think, which are the other medications that may cause lactic acidosis as a side effect? So the first answer that comes is metformin. So if linezolid and metformin are used together, definitely we have to monitor the serum lactate levels of the patient. Metformin is eliminated through renal elimination. So whatever lactic acid is built up, it is eliminated through the kidney. So in CKD patients, if they are diabetic, we usually do not prefer metformin because lactate will not be eliminated. So in such a patient, if linezolid is also used, for example, the patient is having an MRSA infection or vancomycin resistant enterococci infection, so there we have to use linezolid. It can be problematic. This is how we need to connect the dots and study. And if we are able to do this, then I can personally tell you that the study process, which you find very hectic, will never be hectic. It will be interesting. That is another thing, that when we think like this, when we visualize like this, people will definitely make fun of us. People will mock at us. People will think, why are you thinking so much? But this is the best way to polish your memory. There are so many people around who contact me daily, and they tell me that they are not able to remember anything. They study something today, they don't remember the next day. But this is exactly why it happens, because we are not able to connect the dots. We are simply drawing a lot of dots on the paper, but we are not having the key to how to connect them into a beautiful figure. So, as I said about optic neuritis, this is exactly how you can derive a practical knowledge, that if ethambutol is used in a tuberculoid patient who is also suffering from diabetic retinopathy, it may be a further matter of concern. The most common problem with anti-tubercular drugs is hepatotoxicity, especially the first-line anti-tubercular drugs. They are hepatotoxic in nature. Although the first-line agents except streptomycin and ethambutol are implicated, hepatotoxicity tends to aggravate when first-line anti-tubercular drugs are used as combination therapy. So always remember, first-line anti-tubercular drugs except ethambutol are hepatotoxic in nature. Streptomycin is not directly a first-line anti-tubercular agent, but if you look at the treatment of drug-sensitive TB, and if it is a pre-treatment patient, we actually indicate streptomycin also. So that is why I mentioned it here. So if hepatitis or severe elevation in liver enzymes occur, then we should stop all the drugs and allow the reaction to subside. If it is a case of severe TB, so definitely if hepatotoxicity happens, it doesn't mean that we will stop the tubercular drugs. So we can use non-hepatotoxic drugs. So if you are having severe TB and you are using first-line agents and you develop severe hepatotoxicity, the alternate that you can look is non-hepatotoxic anti-tubercular agents. For example, streptomycin. Streptomycin is nephrotoxic. It is not hepatotoxic. Streptomycin can cause to some extent vertigo as well. And you can add ethambutol to it and 1 fluoroquinolone. The discontinued drugs should be started one at a time. So as I said before, the de-challenge, re-challenge concept. So you can start one at a time, and then you can understand which is the offending agent or agents which are responsible for hepatotoxicity. In general situations, when hepatotoxicity occurs, we usually stop all the first line agents, and we will first start with rifampin. We will introduce rifampin. After 7 days, if there is no hepatotoxicity, then we will introduce isoniazid also. If hepatitis comes back, then we will stop isoniazid and reconstitute the regimen. If rifampin and isoniazid are not the culprits, then we should not restart pyrazinamide, because most probably pyrazinamide is responsible for causing hepatotoxicity. Because as I already told you, ethambutol does not cause hepatotoxicity, and streptomycin is also not a culprit. So if rifampin and isoniazid, when you re-challenge it, if hepatotoxicity doesn't happen, that means pyrazinamide is the culprit. So avoid pyrazinamide. You can prolong the treatment with rifampin, isoniazid, and ethambutol for 9 months. If rifampin is implicated in hepatitis, then we can give isoniazid plus ethambutol plus streptomycin for 2 months. You can follow it up with a combination of isoniazid and ethambutol for another 10 months. Why? Because as I told you, in the continuation phase or in the maintenance phase, we do not use pyrazinamide. We do not use any injectables. Streptomycin is an injectable. If isoniazid is causing hepatitis, then you can give a combination of rifampin plus ethambutol plus pyrazinamide for 9 months. Now we'll come to DELAMANID, which is a new introduction in India. As I said, it is 3 to 4 years old now. It comes under nitroimidazoles. We have other nitroimidazoles also, like for example, metronidazole, tinidazole. They also come under nitroimidazoles. So DELAMANID shows bactericidal effects in 2 ways. Number 1, it blocks mycolic acid synthesis. As I told you in my first video about RNTCP, the most difficult thing about Mycobacterium tuberculosis therapy is that its outer coating, and that is called mycolic acid. That is why common antibiotics we cannot use, because it can't penetrate. So this drug blocks mycolic acid synthesis, so prevents bacteria from building blocks which are important for cell wall synthesis. So that causes bactericidal activity. And another mechanism is, it has a dual mechanism. The second mechanism is, it poisons the bacterial cells with NO. NO is nitric oxide. So that also destroys the organism. Its half-life is approximately 36 hours. Why DELAMANID? Because this is one of the 2 drugs, the other one being bedaquiline, which was developed for the treatment of MDR and XDR TB. DELAMANID was first approved by the European Medicinal Agency in November 2014. It is indicated to be used as a part of an appropriate combination regimen for pulmonary MDR TB in adults and adolescents in cases of refractory or drug intolerance TB cases. So you can understand what I meant. It is to be used in adults and adolescents, not less than the age of 6. In cases of refractory TB means if it is multi-drug resistant TB or extensive drug resistant TB. Refractory means it is not responding to the standard medications. And drug intolerant, you know very well, if the first-line anti-tubercular are causing severe side effects, the patient cannot tolerate it, then we can use DELAMANID as an option. When can we use it? In conditions where an effective MDR TB regimen in addition to pyrazinamide cannot be designed. That means either pyrazinamide cannot be used, or if you look at the MDR TB regimen, which I explained in the previous video, there any of the drugs cannot be used. So if you can't properly make an MDR TB regimen, due to contraindications or due to resistance, then we can use DELAMANID. If there is a documented evidence of resistance to fluoroquinolone or second-line injectable, in addition to MDR, in that condition also you can use DELAMANID. So for example, fluoroquinolone is resistant and aminoglycoside is resistant. In that condition also you can use that. Conditions of poor clinical outcome. Poor clinical outcome means whenever we give a therapy, we try to analyze whether the patient will recover or not. So if there are conditions of poor clinical outcome, which include drug intolerance, that means the patient cannot tolerate the side effects, contraindication. So you are using a particular molecule in a patient who is already having a disease condition in which we cannot use this medicine, or extensive or advanced disease. For example, the patient is having HIV plus this condition or severe tuberculosis. In those conditions, DELAMANID can be used. When should we not use DELAMANID? Children less than 6 years, because the safety profile has not been analyzed properly. Pregnant and lactating women, to some extent, because this medicine actually has cardiotoxic problems also. So it may not be a good option in pregnant and lactating women. Patients with repeated demonstration of QT interval greater than 450 to 500. That means if a patient is having cardiac conduction abnormality in which QT interval prolongation usually happens, or if the patient is suffering from a type of arrhythmia known as torsidos de points, in that condition we cannot use DELAMANID. If the patient has a history of torsidos de points or any other kind of cardiac function abnormalities, or if you are hypersensitive to the drug or to its extreme. This usually we say for every medicine. If you are hypersensitivity to it, or if you are hypersensitive to it or allergenic to it, we should not use. What are the potential risks of DELAMANID? Treatment with DELAMANID should not be initiated unless benefit is more than risk. So for example, if you already have a history of QT interval prolongation, DELAMANID should not be used. If you had a history of any kind of cardiac conduction abnormalities or arrhythmias, DELAMANID should not be used. If you have any kind of cardiac disease which can lead to arrhythmia, for example, if you are having severe hypertension that can cause arrhythmias, if you are having left ventricular hypertrophy or left ventricular dysfunction, that can also lead to arrhythmias. So in such condition, if you are using DELAMANID, it may be a problem. So consistently, we have to monitor the ECG. So whenever we give DELAMANID to a patient, before starting the therapy, we should see the ECG of the patient. And then after 15 days of treatment, we should again see the ECG of the patient. And then on a monthly basis. That means it is called baseline. So how should we monitor? First, before giving the drug, we should monitor the ECG. If it is okay, then after 15 days, we should monitor, and then on a monthly basis. Yes, if the patient is already suffering from arrhythmia or QT interval prolongation, but we have to use the medicine because of benefit outweigh risk thing, then in that condition, we should monitor ECG frequently, maybe every 2 to 3 days or on a weekly basis. If the patient is suffering from hypokalemia, hypocalcemia, or hypomagnesemia, because these all conditions can lead to cardiac arrhythmias. Always remember, hypokalemia, hypocalcemia, and hypomagnesemia can lead to different types of cardiac arrhythmia. So if you are a patient who is already suffering from this, all this kind of electrolyte imbalances should be normalized before starting DELAMANID therapy, or else it can aggravate cardiac arrhythmias. If your QT interval is greater than 500 millisecond, and if you are taking any medication which prolongs the QT interval, for example, you are taking quinine or quinidine, or you are taking any kind of fluoroquinolone, or you are taking erythromycin, which prolongs the QT interval, along with that, you should never use DELAMANID, because already you are suffering from QT interval prolongation. And if two medicines are used together, then it can be life-threatening. If you look at the drug interaction, DELAMANID can prolong the QT interval in a very severe manner if it is administered with macrolides, especially erythromycin, roxitro, and to some extent clarithromycin. Azithromycin has a very less risk of QT interval prolongation. If you are using it along with fluoroquinolones, especially levofloxacin, moxifloxacin, tricyclic antidepressant, if you have studied toxicology, you have studied TCA poisoning, you know very well that tricyclic antidepressant usually cause QT interval prolongation. Triazole antifungals, to some extent, they also can cause QT interval prolongation. Non-sedating antihistamines, as I said before, these antihistamines are no longer used because they have caused a lot of mortality due to cardiac problems. Astemizole and terfenadine are not used nowadays. Neuroleptics. Neuroleptics means they are also known as antipsychotics. So there are a lot of antipsychotics which cause QT interval prolongation or cardiac conduction abnormalities. As far as I remember, there is a molecule known as ziprasidone. Ziprasidone is a second generation antipsychotic and it has a very high risk of QT interval prolongation. So for example, it is a schizophrenic patient who is under ziprasidone therapy and you are giving DELAMANID to that patient, which also prolongs the QT interval, then the condition of the patient will not be good. So you may have to switch the antipsychotic to something else. And saquinavir also causes QT interval prolongation, so we should be very careful. What are the strategies? See, always we say that a newer antibiotic has come, a newer antiviral has come, it is a blessing, it is this, it is that, we keep on saying. But finally what happens, we use it so much, we use it so unnecessarily that resistance develops. So what are the strategies to prevent DELAMANID resistance? Number one, use DELAMANID only with appropriate combination regimen for MDR-TB. And number two, you should never add DELAMANID to a failing regimen. Failing regimen means, for example, you are using isoniazid or rifampin in tuberculosis and both of them are resistant. In that condition, if you are adding DELAMANID to the therapy also, and isoniazid is also going on at the same time, then DELAMANID may also get resistant or it may become ineffective. So never use DELAMANID to a failing regimen. DELAMANID should always be used in combination with those kind of anti-tubercular agents which actually respond or are effective against Mycobacterium tuberculosis. As far as extrapulmonary TB is concerned, you know what is extrapulmonary TB? If that tuberculoid granuloma is spreading to the different parts of the body, in the brain it causes tuberculous meningitis, in the bone it causes skeletal TB, in the stomach it causes GI TB or abdominal TB. So as long as benefit outweighs risk, DELAMANID may be used. But till now, there has not been much of a study about the role of DELAMANID in CNS TB. In CNS TB, we usually do not use DELAMANID. But if it is a failing regimen or if it is a multi-drug resistant TB or something, as per the Gen Expert test or any kind of gene test, then maybe we may start DELAMANID. Again, as I said, although I have mentioned the dosage regimen here, as I always tell to people, this is my personal advice to everyone. You should never feel bad if you don't remember the dose. Yes, you should always feel bad if you are dealing with that medication on a daily basis in the hospital. And if you still don't remember the dose, then definitely you should feel ashamed. But if you are not habituated with this medicine in your practical scenario, and if you don't remember the dose, never feel bad. Actually, when we go for interviews or, when we go for rounds or whenever we go, when doctors ask us or any time when we are interviewed by people, they usually ask us the dose of medicines. But it is not necessary that we have gone to the hospital and, we have seen such kind of cases, so we may be able to remember the dose properly. You know what are the different challenges of a dose? For example, if I tell you that the dose of a particular medicine is 500 mg, it doesn't mean that the dose ends there. First of all, we have to know how many times it should be used in a day. We have to know what are the different dosage forms available. We also have to know what are the different salt formulations available. A particular medicine can come in different salt formulations also. We also have to know if the patient is having hepatic dysfunction, what is the dose. We also may have to know if the patient is having renal dysfunction, what is the dose. And even if the patient is having hepatic or renal dysfunction, in different stages of hepatic and renal dysfunction, what are the doses? So like this, if you start to remember the dose of individual medicine, I can guarantee you that you will never reach any. So as I said in my video on thiazide diuretics, dose can only be remembered in 2 or 3 ways. Number 1, personally you have taken that medicine, or your family or anybody close to you, so you have habituated with that. Number 2, go to the hospital and take such cases so that you may get habituated with that frequently. And number 3, study dose dependent side effects. Like for example, if risperidone, the dose is above 6 mg per day, definitely you will have extrapyramidal symptoms related side effects. Metoprolol, if it is used above 50 mg per day, then it loses its cardioselectivity and it becomes non-selective. So like that, if you study, then maybe you may be able to remember the dose. Otherwise, please don't bother. Please don't feel bad. If people make fun of you, or if you are getting interviewed, or if people ask you and you don't remember the dose, don't feel bad. So generally for children, DELAMANID can be used as 50 mg and 100 mg PD, depending on the age, for a duration of 24 weeks, that is 6 months. Week 0 to 24, the dose of DELAMANID is 100 mg plus the optimized background regimen. Optimized background regimen means the other anti-tubercular drugs which respond to Mycobacterium tuberculosis. And from the 7th month till the end of treatment, you can continue with another second-line anti-tubercular drug. DELAMANID can be taken with food to increase the bioavailability. So we usually advise patients to take it with food so that the bioavailability increases and we get the maximum benefit of the medicine. So that's it with my presentation. So hereby we end the RNTCP guideline series of tuberculosis. It has been a long series of 3 videos. So as I said before, if you appreciate my efforts, because this has never been easy. I had to refer a lot, making the slides, then converting it into my speech in the form of a video, and then talking a lot of things. So if you appreciate my work, then please do subscribe and share to maximum people, because I am doing this free of cost. Whatever knowledge I give to people, I never charge money for it, because I believe that anyways your parents are spending a lot of money on your career, and most of you are still disillusioned as how you are able to justify the money that your parents have invested on. So if I take separately money from you in the name of teaching you, then I think it is a crime. So all of this are free of cost. So if you appreciate my efforts, then please do subscribe and share. I will be back with another interesting video tomorrow. So till then, it is goodbye and thank you for listening.